This lecture will describe the chest X-ray findings of 20 different conditions, starting with atelectasis. This is a chest X-ray of left upper lobe atelectasis. Take a brief moment to observe the radiograph. Is there anything that you can comment on? When presented with an X-ray of left upper lobe atelectasis, the first finding that you may notice is an area of increased opacification. Atelectasis of the left upper lobe results in a hazy veil-like opacity over the left lung that fades out inferiorly without a clear border. Collapse of the left upper lobe results in effacement of the left heart border, obscuring the interface between the heart and the lung. This is referred to as a silhouette sign. Atelectasis may also result in signs of decreased lung volume, which in cases of left upper lobar collapse can include ipsilateral tracheal deviation and elevation of the left hilum. When presented with an X-ray of a patient with right lower lobe atelectasis, the first finding that you may notice is an area of increased opacification. Atelectasis of the right lower lobe results in a triangular density medially at the right lung base. Collapse of the right lower lobe results in effacement of the right heart border, obscuring the interface between the lung and the heart. This is referred to as the silhouette sign. Note that the interface between the lung and the medial aspect of the right hemidiaphragm is also obscured. Atelectasis may also result in signs of decreased lung volume, which can include ipsilateral tracheal deviation, depression of the minor fissure, and elevation of the right hemidiaphragm, a radiographic sign that is referred to as tenting. The chest radiograph of an individual with achalasia may reveal an elongated opacity that overlaps and extends past the right mediastinum, resulting in a convex widening of the mediastinum. If there is stasis within the esophagus, then an air fluid level may be present. The gastric air bubble may be subtle or even completely absent due to the paucity of air passing through the lower esophageal sphincter. Aspergilloma is often manifest radiographically as a focal, ovoid, and non-spiculated opacity, more commonly located in the upper lobes. If liquefaction necrosis occurs, then there may be a central area of radiolucency. A thin-walled area of radiolucency can be found above or surrounding a caveating aspergilloma, a finding referred to as the air crescent sign. A similar finding is present when an aspergilloma forms within a pre-existing cavity. Another interesting point to note is that mobility of the mass can be demonstrated by changing the position of the patient. The breast prostheses in this image appear as bilateral artifactual opacities. The two circular opacities have a homogeneous radial density with sharp borders. The contours of the opacities and their location in the lower thoracic cavity are the typical appearance of cosmetic breast implants. One pitfall to keep in mind is that a unilateral breast implant, such as following mastectomy, can mimic lung infiltration or pathologic process. Congenital herniation of abdominal viscera, such as intestine and liver, into the thoracic cavity can result in ipsilateral absence of aerated lung and a contralateral mediastinal shift with lung compression. Characteristically, multiple loops of air or fluid-filled bowel are seen in place of the lung. If the herniated loops of intestine are filled with fluid, then the affected hemithorax will be radioopaque. If there is herniation of the liver into the right hemithorax, then the typical liver shadow will be absent below the diaphragm, while a large soft tissue opacity will be present above it. In this X-ray, in addition to the presence of intrathoracic intestine, we can also note the lack of a gastric air bubble below the left hemidiaphragm and the presence of intestine below the right hemidiaphragm, an area usually occupied by the liver. Cardiomegaly, particularly in concert with other findings, is a suggestive feature of congestive heart failure. However, keep in mind that congestive heart failure can occur in the presence of a normal-sized heart. Cardiomegaly is said to be present when the cardiothoracic ratio is greater than 0.5. That is, when the largest transverse distance between the left and right heart borders of the cardiac silhouette is greater than half the width of the thorax. In this image, the cardiothoracic ratio is approximately 0.6. Now, you should also be aware that on anterior-posterior films, determination of heart size is unreliable due to magnification. Vascular redistribution is one of the first signs of congestive heart failure. Increased blood flow to pulmonary vessels in the upper lung zones results in an increase in size relative to blood vessels in the lower lung zones. This caudal to cranial redistribution of blood flow should only be inspected for in an erect X-ray, since equalization of blood flow may occur in the supine position. The finding of upper lobe blood diversion, however, can be difficult to appreciate on a plain radiograph. One other way that it can be identified is by the discovery of a superior lobe artery with a greater diameter than its accompanying bronchus. Now, since it is hard to be certain on this radiograph, this example should be taken for illustrative purposes. The bronchus is the ring-like structure with a hollow center, while the artery is filled in. Normally, the upper lobe artery to bronchus ratio is less than 1:1. Here the reverse is seen, with a larger artery than bronchus. You may have also noticed the prominence of the hilar region and the widening of the vascular pedicle in this radiograph. The fullness of the right hilum is particularly evident, whereas the left hilum is predominantly obscured by an enlarged cardiac silhouette. Unlike with lymph node enlargement, in which case the hila can appear as a large lumpy mass, the hilar region in this X-ray has irregular borders due to thickened outward branching vessels. The increase in hilar size, as well as the vascular pedicle widening in this X-ray, are due to pulmonary venous congestion. An edematous interstitium is another important feature of congestive heart failure. 3 signs of thickened interstitial tissue include curly B-lines, peribronchial cuffing, and interlobal fissure thickening. Curly B-lines are fine linear opacities that are only 1 to 2 mm in width. They are typically located peripherally in the lower lung fields near the costophrenic angles. When viewed close up, they can be seen to extend perpendicularly inwards from the pleura and are up to 3 cm in length. These opacities can also be seen head-on, in which case they are referred to as curly C-lines, or radiating outward from the hila, in which case they are called curly A-lines. Peribronchial cuffing is another discrete finding which occurs due to edema of the bronchial wall. When viewed head-on, it appears as a donut or a ring. When viewed tangentially, that is from the side, it appears as 2 parallel lines, which to some extent resemble tram tracks. Note that peribronchial cuffing can occur in other conditions as well, such as chronic bronchitis. Also evident in this image is a thickened minor that is horizontal fissure. This finding is easier to detect on a lateral radiograph where both the oblique and horizontal fissures may be visible. Collectively, interstitial edema results in widespread blurring of lung markings. The loss of definition results in a hazy appearance of the lung fields and hilum bilaterally. Now let's turn our attention to the bottom right corner of the radiograph. Note that there is a decrease in definition of the left costophrenic angle, a finding that is consistent with a pleural effusion. The ingested foreign body seen in this image is circular with sharp borders and has a homogeneous radiopacity. This combination of findings is more consistent with a coin than a button battery, which usually has a double radiolucent rim, also known as a halo sign. The opacity is seen at the level of the cricopharyngeus and is most likely within the cervical portion of the esophagus. A lateral radiograph would help confirm that the object is within the esophagus as opposed to within the trachea. Also worth noting is that ingested foreign bodies typically become impacted in the coronal plane. And one pitfall to keep in mind is that swallowed objects may be radiolucent, and thus a normal X-ray does not exclude foreign body ingestion. Hiatal hernia usually presents radiographically as a well-defined, rounded retrocardiac opacity with an air fluid level. In many cases of hiatal hernia, there will not be an air bubble below the left hemidiaphragm. This is a relatively expected finding considering that the stomach is no longer in its usual position. One pitfall to consider is that hiatal hernias can look similar to a retrocardiac lung abscess or another cavitary lesion, but it will change in size and shape between radiographs. Here is another chest X-ray taken of an individual with a hiatal hernia. Note the retrocardiac opacity with an air fluid level. This lateral plane radiograph is from the same person as the previous image and better depicts the position of the hernia posterior to the heart. A lung abscess typically appears as a focal round mass with a central cavity and a gas fluid level. The outer wall of the cavity is poorly defined due to surrounding consolidation, while the inner margin is relatively sharp. Within the cavity is a collection of gas and fluid. A sharp horizontal line divides the dark radiolucency, the gas, from the dense opacity below it, the fluid. While looking at this chest X-ray, the first thing that may come to your attention is the unusual appearance of the cardiac silhouette. It has a large and globular shape, which apparently resembles an old-fashioned leather water bottle. Now, regardless of any visual similarity, the name is fitting enough since the precardial sac is filled with fluid. More objectively, however, the cardiothoracic ratio in this image is approximately 0.6, which is larger than normal. On a posterior-anterior radiograph, such as this one, the cardiothoracic ratio should be less than 0.5. Now, on a bit of a side note, this value is not measured on an anterior-posterior radiograph because overmagnification of the heart would give an inaccurate estimation of its size. And finally, inspection of the airway reveals that the lower trachea is not quite vertical and that the carina appears to be displaced to the right. This appearance can occur if the X-ray was performed while the patient was rotated to the right. As well, encroachment of the engorged pericardial sac on the lower airway can also push the carina away from the midline. This is a plain radiograph of an individual with pleural effusions bilaterally. The first abnormality that is readily apparent is the dense homogeneous opacity that is present in the costophrenic angles. Unlike with consolidation, air bronchograms are not present. Because of this dense opacity, the interface between the fluid and the heart border and hemidiaphragm is indistinct. This is known as the silhouette sign. Similarly, the costophrenic angle is completely obliterated due to the presence of pleural fluid. The fluid forms a meniscus with a concave upper border and an ascending lateral tip. The diagnosis of a pleural lipoma cannot be made on the basis of a plain radiograph alone. Nonetheless, there are a few findings that can help suggest a diagnosis. On a chest X-ray, it appears as a focal homogeneous opacity with a convex bulge and a sharp border. Also very important is that there is no evidence of bone destruction, such as rib erosion. The radiographic appearance has been likened to a snowball after having made impact with a wall. Note that the edges of the mass are tapered and there's an obtuse angle between the lung wall and the contour of the lesion. When presented with an X-ray of a patient with right middle lobe pneumonia, the first finding that you may notice is an area of consolidation. The presence of fluid density material within the right middle lobe results in a wedge-shaped opacity in the right lower zone adjacent to the heart. Another finding that is a little more difficult to appreciate is the presence of air bronchograms. Air-filled bronchi that are surrounded by alveolar infiltrates can appear as dark, radiolucent branching columns within the area of opacification. Consolidation of the right middle lobe results in effacement of the right heart border, obscuring the interface between the lung and the heart. This is referred to as the silhouette sign. Lastly, note that the superior border of the right hemidiaphragm is clearly defined. This helps to differentiate a right middle lobe pneumonia from right lower lobe pneumonia, in which case the right hemidiaphragm would be obscured. Pneumoperitoneum refers to free gas in the peritoneal cavity, and it appears on an erect chest radiograph as a subdiaphragmatic lucency. The green arrows demarcate the right hemidiaphragm, which appears radiographically as a thin white line. The red arrows demarcate the upper border of the liver, and between the liver and the right hemidiaphragm is a thick crescent of air. Sandwiched between the blue arrows is a portion of gas-filled colon. Adjacent to it is free air under the left hemidiaphragm. Here's a much less conspicuous case of pneumoperitoneum. Notice the thin area of increased blackness between the diaphragm, which has been highlighted in purple, and the liver beneath it. Here the subdiaphragmatic air is highlighted in blue. The crescentic lucency is not always easy to see, so you may need to look closely. The plain radiograph of a patient with a pulmonary infarction can be deceivingly normal, without any striking abnormality identifiable. In this X-ray, we can see a sign that is known as Hampton's hump. The wedge-shaped opacity in the periphery of the lung is a rare but suggestive finding of pulmonary infarction. The base is juxtaposed to the pleural surface, while the rounded apex, that is the hump, is angled towards the hilum. A pneumothorax refers to the presence of gas or air in the pleural space. It is considered a simple pneumothorax when there isn't any mediastinal shift to the contralateral side and the patient is stable. In regards to detecting a pneumothorax, the most important aspect is simply looking for it. The X-ray may be almost entirely normal, except for a small crescent of lucency next to the lung, which can be easy to miss. Can you see a crescent of increased transradiancy in this X-ray? You may need to look closely. This area of increased blackness represents free air. Notice the lack of bronchovesicular markings within this region. A very helpful sign of a pneumothorax is the demarcation of the visceral pleura on the X-ray, which is identified by a thin, sharp white line. This fine hairline opacity occurs between the lateral border of the lung and the free air in the pleural space. Again, notice the lack of pulmonary vascular markings in the area beyond the pleural line. Now, if the lung is consolidated, then the visceral pleura won't be distinguishable as a separate line, but rather as the edge of the consolidation. Within the confines of the visceral pleural lines, you can see lung tissue, which can be identified by the presence of lung markings. The contralateral lung, however, may appear to have more prominent lung markings due to increased vascular flow. As mentioned earlier, with a simple pneumothorax, the heart and mediastinal structures remain in their natural positions. For example, notice the central position of the trachea in this X-ray. Here's a more obvious X-ray of a pneumothorax. No lung markings are visible beyond the border of the right lung, which has collapsed. Notice the increased opacity of the collapsed right lung in comparison to the normal left lung. As well, the right heart border cannot be identified because the collapsed lung is indistinguishable from the heart. This is referred to as the silhouette sign. And the trachea is central, as mediastinal shift has not occurred. In Situs inversus totalis, all of the visceral organs are located in the opposite side of the body, in mere reflection of the normal position and rotation. As we can see in this image, the cardiac silhouette is located in the right hemithorax, with the cardiac apex pointing towards the right. The descending aorta is also on the right side, as opposed to its usual position on the left. Although this is a chest X-ray, there's also evidence of the mirrored arrangements of two abdominal organs, the liver and stomach. Notice that the left hemidiaphragm is higher than the right, suggesting that the liver is left-sided. And perhaps the least eye-catching feature is the presence of the gastric air bubble on the right, suggesting the presence of the stomach in that location. A skin fold on the chest can result in an abrupt drop-off in opacity, thereby mimicking the radiographic findings of a pneumothorax. A skin fold, however, has a dark band, opposed to a light, at its lateral contour. As well, in the case of skin folds, bronchovesicular markings extend to the periphery of the lung, whereas with a pneumothorax they do not, keep in mind, however, that apical bronchovesicular markings may be difficult to appreciate. A pneumothorax refers to the presence of gas or air in the pleural space. It is considered a tension pneumothorax when the lungs are compressed and venous return to the heart is compromised, thus resulting in hemodynamic instability. Now we're going to take a look at some of the classic chest X-ray findings that are associated with a tension pneumothorax. The edge of the lung is clearly demarcated. This is the visceral pleural edge. Bronchovascular markings are typically absent beyond the visceral pleural line, resulting in an area of increased transradiancy, that is, blackness. This area is filled with free air. Now, unlike with a simple pneumothorax, the ipsilateral hemithorax will be enlarged, while the lung within it may be partially or extensively collapsed. As well, the heart and mediastinal structures, such as the trachea, may be shifted away from the side of the pneumothorax. With a tension pneumothorax, we may also see ipsilateral diaphragmatic flattening and rib splaying. The term boot-shaped heart refers to the abnormal appearance of the cardiac silhouette. Two of the four classic defects that contribute to this appearance are a ventricular septal defect and pulmonic stenosis. This combination of defects results in an elevated right ventricular systolic pressure with ensuing right ventricular hypertrophy, which is a third defect in the classic tetralogy. In this radiograph, right ventricular hypertrophy has resulted in an upturned cardiac apex that is positioned abnormally high above the diaphragm. Pulmonic stenosis can also result in a small main pulmonary artery due to decreased flow. This finding is depicted on the X-ray as an increased concavity of the main pulmonary artery segment. The fourth defect is an overriding aorta, which along with pulmonic stenosis and a VSD facilitates the shunting of blood away from the pulmonary system. This results in a large aorta, which in a significant proportion of patients is right-sided, and decreased pulmonary vascularity, oligemia, which is visualized on this X-ray as diminished lung markings, that is, increased blackness of the lung fields. Now for a quick review. The four findings in this radiograph of a boot-shaped heart include an upturned cardiac apex, a concave main pulmonary artery segment, an enlarged aorta, and oligemia. Before we get started, I would like to bring your attention to the sternotomy wires that are visible in the midline. These indicate prior intrathoracic surgery and can provide an important clue when details regarding the patient's prior health cannot otherwise be obtained. Also take a moment to observe the cardiothoracic silhouette. The size and contours of the heart are relatively normal in this patient. Now let's address the widened mediastinum. The large mass has a homogeneous density with sharp margins, and it extends out laterally on both sides. The ascending aorta, the aortic arch, and the descending aorta are all dilated. When the aneurysm only involves the ascending aorta, the bulge typically appears on the right side of the chest, and when the dilation is extensive, the ascending aorta may form the upper right border of the cardiac silhouette. Dilation of the descending aorta, as may be expected, results in a left-sided bulge. The absence of the descending aortic shadow in its typical location provides further evidence that the mediastinal widening is due to aortic disease. Calcification of the outer wall can occur, particularly with acquired aneurysms, but it is not present in this case. Finally, take note of the convex bone of the trachea. The aortic arch is a structure in the superior mediastinum, and when it is significantly enlarged, it can displace the trachea rightwards and the left main bronchus downwards. When considering the possibility of a thoracic aortic aneurysm, you should keep in mind a few caveats. A rotated X-ray can give the appearance of mediastinal widening. The aorta can be quite tortuous in the elderly. Mediastinal masses such as a thymic tumor can appear very similar, and small aneurysms may not be detectable with plain radiography. In this example, the first abnormality that may come to your attention is the globular or oval-shaped cardiac silhouette. The unusual heart shadow occurs due to prominence of the right atrium and convexity of the left ventricle. In more classic examples, the right atrium protrudes out more laterally and the oval shape of the heart looks like it's tilted sideways. The second abnormal finding is a narrow vascular pedicle. This occurs because the thymic shadow is typically smaller or absent, and the pulmonary artery lies directly behind the aorta. On a lateral radiograph, however, this front-to-back orientation of the aorta and pulmonary artery would result in a wide superior mediastinum. Overcirculation of pulmonary blood flow results in a third finding, represented on plain radiography as an increase in vascular lung markings. The combination of an oval cardiac silhouette and a narrow vascular pedicle has been visually described as an egg on a string. Now, while the combination of these findings results in a classic appearance, it is important to keep in mind that in many cases the X-ray is completely normal.